Thank you very much, Birgit. Thank you very much for the invitation. It's a great pleasure to be here. As Robin stated very well, the time for the management of bloodstream infection and in particular blood culture is very important. Also because now the concept of a golden hour is evolving a lot. This is a nice paper published last year, which highlighted the time that the clinician can wait before the wait is impact on the mortality. And as you can see here, for the mortality, at 30-day mortality increase only after 12 hours from blood culture collection. So this gives us some time to work on the blood culture and try to provide more information to the clinician. The other very important point is the communication of the results to the clinician. This is a fantastic study, in my opinion, from Spain, which report that the delay in information of positive blood culture or results of blood culture impact a lot on mortality. And so these 2 points have to be kept in mind. For sure, because the time is essential, in our lab we tried to work on all 3 phases of the analysis of blood cultures, so the pre-analytical time, the analytical time, and the post-analytical time. From the first point, the pre-analytical time, we performed several studies to try to underline the better approach for the management of blood cultures. For instance, it is not reported in the slide, but for instance, from March 2022, we are 24/7, and this is very important because we reduced a lot the time to results. We are a continuous monitoring of the blood culture, and we have some also educational process to learn to the persons to correctly manage the blood culture before the culture. So this is the results are related to the automated continuous monitoring that allow a fast TDT compared to standard incubators, and also the importance of neutralization media. But for sure, the most important impact could be about the analysis. This is the complex process we have in the lab. This is real life. This is not something for studies. This is our real life. We perform in parallel either standard culture, so gram stain, subculture on solid media, and so on, MALDI identification, of course. And in the same time, we try to speed up the process, performing immediately some analysis. For instance, the most important is the direct MALDI testing from positive blood cultures, and in particular, this is very important because the use of MALDI, as previously demonstrated in this very nice paper from Adrian Egli, is very important in reducing the time to identification and also the time to treatment. So the immediate evaluation by MALDI of the positive blood culture, in our opinion, is absolutely important. Unfortunately, we are a high-level resistant country, unfortunately. This is quite a pity, of course. These are more or less the percentage of the infection, invasive infection last year, and you can see the numbers. Numbers are not so good. So we need to provide to the clinician immediately results that can help in the management of the patients. And we, for instance, in the past used this approach. This is a molecular test able to identify several markers for beta-lactam resistant, carbapenem resistant in E. coli and Klebsiella pneumoniae. And as you can see, the empirical treatment at the beginning of the story was quite low. The appropriate empirical treatment was only 21%. But after the implementation of the system and the communication of the results to the clinician, the appropriate treatment increased to 84%. And so this is absolutely important. And another possible approach is not only molecular, but it's possible also to perform an immunochromatographic approach. We use routinely this approach, and this is a nice systematic review about the impact, the role of the immunochromatographic test to manage positive blood culture, to detect determinant of resistance. Unfortunately, now we have some problems because is increasing the number of KPC variants, and the KPC variants are induced by, for instance, ceftazidime-avibactam treatment, and we have also this in Italy, a problem for this. And unfortunately, these tests are some of the chromogenic tests and the immunochromatographic tests are unable to detect the KPC variants. So we need to refine our approach to have better results. And of course, and this was brilliantly presented by Robin, of course, this approach with MALDI is very good if the blood culture is monomicrobial. If it's polymicrobial, it's necessary to use another approach together with the MALDI. And of course, a multiplex system is very useful to this aim. These tests are absolutely effective. As you can see, this is a very large systematic review on the methods. Of course, the table are unreadable, of course, and sorry, but I reported the results at the bottom of the slides. So the molecular tests showed a very high sensitivity and specificity. So this test works very well. The problem is implement in the real life. This is a paper we published some years ago about when we started this story, and we analyzed a lot of BSI episodes, and as you can see here, the causative organisms were very well identified, and we saved a lot of time implementing this approach in our workflow. And this also is not reported, is in another paper. It had an impact also on the length of stay, probably related to the number of multi-drug resistant tests performed, microorganism identified. So, on the basis of this, unfortunately, because some tests are not so good, some molecular tests, because also the KPC variant is a big issue also for molecular tests, because if I detect a KPC, I have to know which type of KPC I have, at least for patients with possible ceftazidime-avibactam resistance. So we need some rapid AST, and this is the future, in my opinion. There are several approaches possible. The first is the UCAST Trust. You know very well this. There are the guidelines published by UCAST for this approach, and the other possibility already stated by Robin before is the possible use of a rapid phenotypic AST directly from positive blood culture. Here I reported some of the tests available, and of course I will speak about Vitecril because is in process the evaluation in our lab, and we hope to implement in the real life. So we performed a simple study, validation study, and as you can see, either the essential agreement or the categorical agreement are quite nice. Please note that this study was performed using as comparator the broad dilution method, not another commercial method. I think this is the right approach to have very solid results. And now, and this study was presented by Dr. Damiano Squitieri yesterday in Azora Communication, the possibility to have some comparison between different rapid AST systems. And in this study, as you can see here, performed on 120 clinical positive blood cultures, not spiked, only real. We used the Vitek reveal, the direct Vitek 2 directly from positive blood cultures, and also the UCAS Trust. And of course, also in this case, the comparator was the reference method, the UCAS reference method performed in broad microdilution. These are the test performed. And the other point, also in this case, we obtained very good results because as you can see here, either the categorical or the essential agreement are quite high in particular for Vitek reveal, but also for Vitek 2, and only the categorical agreement for the Rust system. Very importantly, the time to results was absolutely better for Vitek reveal. As you can see here, we have a median time of 7 hours 45 minutes for the Vitek reveal to obtain the results against the 70 hours for Vitek 2 and 9 hours for the UCAS system that have some problems because some differences because, as you know, it's not possible to have of course, an MSE value using this diffusion. And finally, another point that I want to underline is presented by Dr. Sanguinetti yesterday in the communication is the possibility to identify also some isolates heteroresistant for this approach, because we observed isolate resistant to trimethamine sulfamethoxazole only performing by Rust, by Vitek reveal, susceptible by also the reference method. We observed some differences in the curves, the positivity curves for the Vitek reveal, and we detected that this isolates was a heteroresistant isolate to trimethamine sulfamethoxazole. So it's possible that reveal could be able to identify exactly the heteroresistance. So to finish the story, of course, it's very important also in this workflow to provide results to the clinicians, and this is very important, the importance of the diagnostic stewardship and to have a microbiology in the antimicrobial stewardship team. The good communication is absolutely important. And we implemented also this. We have two types of communication, a readback call to an infectious disease physician immediately after the results, and also, as you can see here, the possibility to have a computerized microbiology alert visible on the department dashboard. So immediately the department, the ward, have the information about the positivity of the blood culture, not only by phone, but also electronically. I think that this is quite important. And this means that using this approach, the mean time for the communication in our real life, this is results obtained by laboratory consultation performed within bioMérieux. The mean time of communication, the time to preliminary report, is 3 hours and 38 minutes, and the final time to AST is only 70 hours. So I think that this is quite important to communicate, to have a good result for the clinician, to change, of course, the therapy. And to finish, I think that is very important, as Robin already stated, but this is important to underline again, that all this approach works only if we have in place an antimicrobial stewardship program. This is absolutely important, as you can see here in this paper. Exactly the problem is that we can have results only for our patients only if the communication of the results is into this type of program. So to conclude, Of course, the rapid diagnostics test, the molecular rapid diagnostic tests are essential, but are not enough, in particular for situations similar to the situation in my country, in which the resistance is quite high, but now, unfortunately, the resistance is growing around the world. And, of course, the demonstration of the benefit of this so-called fast microbiology depends on the institution infrastructure, and this is very important. This has to be a goal for all the hospital, and the effectiveness of communication strategies. So the new diagnostic technologies have to be integrated absolutely into the antimicrobial stewardship program to maximize the appropriate use of antibiotics. Thank you very much to all the persons in my lab that work on this. Some of them are present in this presentation, and thank you to you for your attention.